is now at 41 weeks. Initially, we used to give them a grace period of 2 weeks. And for the mothers who would reach 40 weeks, we'll tell them to come back after 2 weeks, that is after 42 weeks, if they had not given birth. But right now, we are only giving them 1 week. And if they've not given birth, they're supposed to come back to be examined and to determine the mode of delivery. There is a note here which is saying intermittent preventive treatment of malaria in pregnancy should be started at around 13 weeks and it should continue up to 40 weeks. That means they will also have that prophylaxis for anti-malarial for more than 4 times, like the way it used to be before. Now, let's go to the new WHO AC model of 2016. The first contact, we are going to go through the time of the contact and the services which are being offered during these contacts. As you can see in the first contact, we do the baseline investigations that are usually done, the ones that we call antenatal profile. If you can see on the screen, there is full blood count and not HB. Now, full blood count, full hemogram is the one which is recommended instead of HB. And also, they also do blood grouping. And then we do urinalysis. We do random blood sugar. Random blood sugar was not there before, but right now it is recommended. HIV testing and TB screening. And then the test for syphilis. And we are also supposed to do an early off scan. In addition to the usual history taking and physical examination, clinical examination, and then we do education on danger signs, nutrition, breastfeeding, hygiene, and common symptoms encountered. These are the common symptoms encountered during pregnancies. And then we're also supposed to offer nutrition supplementation, that is the IFAS, and we are also advised to give calcium, to take blood pressure measurements and weight in each contact. There is also a note at the end, we are told HB to be taken once in each trimester. That is, if we cannot do full hemogram, but full hemogram in this model, it is the recommended test. And then the second contact is around at 20 weeks. The services that are supposed to be offered, we are supposed to do an early obstetric scan, 18 to 20 weeks. And then we offer prophylaxis for antimalarials at 13 weeks because the woman is already past 12 weeks in this contact. And then the prophylaxis for antimalarial should continue every 4 weeks apart until delivery in malaria endemic areas. And Mombasa is one of the malaria endemic areas. And we're also supposed to deworm them with mebendazole, 500 milligrams. Mebendazole is the drug of choice. So let us not use any other drugs. Mebendazole is the one which has been found to be safe to be used during pregnancy. Then HB to be taken once in each trimester. And also we're supposed to educate them on importance and component of antenatal and IFAS discussion. Then the third contact is around 26 weeks. For the mothers who had a negative blood test, at this stage we are supposed to do a COMS test for rhesus negative mothers prior to anti-D administration. And then a prophylaxis anti-D administration should be at 28 weeks for the rhesus negative mothers. And we also educate them on danger signs during pregnancy and importance of facility delivery. In addition to what I've said in these two contacts, we also offer the other antenatal services, the history, whereas you assess from the history that you had taken earlier, and not forgetting to do the physical examination, including the palpation. Now the fourth contact is around 30 weeks. Here we also continue with the same. care that we give in antenatally, there is taking the physical examination. In addition to that, in this contact now, we educate the mothers on individual birth plan. Danger signs and importance of exclusive breastfeeding. The mother is already past 28 weeks. We are now preparing them on delivery. That is why we have started educating them on individual birth plan. They need to be prepared where they are going to deliver. They need to have their insurance cover if it is the Linda Mama or the NHIF or any other cover. They need to have identified the health facility that they are going to deliver. And it is also advisable that they go and visit that health facility. And when they come to our health facilities, we are supposed to give them an orientation of the place where they are going to deliver so that they see. You also introduce to the staffs who are going to deliver, create a very conducive environment for them before they even deliver. They're supposed at this stage to identify a birth companion and prepare the package that they usually carry to go with for delivery. In the fifth contact at 34 weeks, we continue with the same care, antenatal care, that's the clinical examination. And at this stage, they're also supposed to do another OB scan. We do abdominal examination and risk assessment. We continue with the birth preparedness advice. We repeat HB to be taken in each, as I had said earlier, it's supposed to be taken in each trimester. And then we educate them on care of the newborn, early initiation of breastfeeding, and positioning and attachment. And not only educating them, we are supposed to be showing them physically how to position and attach. And at this stage, we are supposed to counsel this mother on postpartum family planning. As you can see, we are already preparing this mother on delivery, on how to take care of the baby, and family planning postpartum, early postpartum, so as we prevent unintended pregnancies. And in the sixth contact, in addition to the same care that we give, we start teaching them about kangaroo mother care, thermal care of the newborn, and cord care. Seventh contact at 38 weeks, in addition to the antenatal care of history and physical examination, we now teach them signs of labor. So as when they start experiencing the signs of labor, they know that they're already in labor and they go to the health facility for a skilled delivery. And at this stage, we recap on essential newborn care so as to equip these mothers with this knowledge to enable them to take care of their infants. Contact number 8 is usually at 40 weeks. In addition to history and the examination, we repeat the signs of labor. We do labor exercises with them. We repeat postpartum family planning, education, and then we recap on essential newborn care. As you can see, this has been emphasized in the two last visit so as to enable these mothers to be able to know how to take care of their baby, to keep them warm, to feed them so as not to, for the newborns to have hypothermia or go into hypoglycemia or any other complications. They even taught on the danger signs that they can observe, so as to enable them to equip them with this information so as to know when to come back immediately when there is a danger. At the end of the slide, as you can see, we are reminded again that at 41 weeks, if labor has not commenced, they are supposed to return to the health facility. Now let us compare the new model of care and the FUNC. FUNC, they used to come only for visits. The first visit was between 8 to 12 weeks. As you can see, in the new model of care of 2016, these mothers are supposed to come immediately they realize that they are conceived up to 8 weeks. And then in FANC, they used to come for the second visit between 24 and 26. The new model of care, by that time, they have already come for 2 visits. That is the second and the third contact. In FANC, the third trimester, there were only 2 visits at 32 and 30, and the fourth one between 36 and 38. As you can see, there were 2 more weeks, which were the clients used to be given an open appointment after they had completed that 4th visit. But in the new model of care, we are having contact 4 to 8. That is from 30 to 40 weeks. So we are with these mothers constantly and frequently. We are having an opportunity to assess them frequently, identify any challenge that might arise, any emergency any condition that might arise that needs to be taken care of immediately in order to prevent complications and morbidity for both the mother and the baby. Now in the new model, we have the mandatory NC profile. TB, HIV, syphilis, these were there in the previous model of care. Blood sugar was not there. Right now we are supposed to do blood sugar. And you can see we are not having HB, but full hemogram. However, it is recommended that if a facility does not have a full capacity to do a full hemogram, they are allowed to do HB. So let us not chase clients let us not refrain from doing an HB because we do not have a full hemogram. For those level 2 and level 3 facilities which do not have a full hemogram, they can do an HB. But for the level 4 facilities, and some of our level 3 and 2 are having full hemogram machines, now it is recommended to do a full hemogram instead of HB. And we also test for malaria, blood grouping and rhesus factor, urinalysis, and hepatitis B. Key recommendations of care. The first one, nutrition intervention. We are supposed to counsel our client about healthy eating and counsel them on how to keep physically active. We are supposed to counsel and make sure that they take their iron and folate.
Let's unmute. Let us mute kindly and allow the facilitator to have a small plan, please. Continue, Amina.
Thank you. It has been noted that, my dear colleagues, it has been noted that these mothers take the IFAS, the iron and folic, but very few of them take them. So we have a responsibility to educate them on the importance on why they need to take this IFAS supplementation. In fact, they're supposed to take it during the preconception period. Before they even conceive, they're supposed to start taking the IFAS. And when they conceive, they're supposed to take it throughout. For those with good HBs, we give them prophylaxis dose. For those with anemia, we will be treating anemia. And we're also supposed to do maternal and fetal assessment. FHG testing is recommended method for diagnosing anemia, as we had said earlier, but if not available, we do HB. The other recommendation is that healthcare providers should ask clients about alcohol intake. Most of the time, we assume women are not alcoholic. Women don't take alcohol, but you'll be surprised if you take history. So we are supposed to ask them about alcohol intake and other substance early in pregnancy and at every visit, so as we can advise them and we can care for them accordingly to prevent complications for the baby. And also HIV testing is considered as a routine component package of care. And here we are supposed to follow the algorithm, the national algorithm for HIV testing, where the mothers should be tested at first visit, and then after 3 months or during 3rd trimester, labor and delivery, and 6 weeks postpartum, and we continue according to how the results come out. Fetal assessment, 1 ultrasound scan, if we cannot do in each trimester. If you can remember in the earlier study, I had said that it is recommended that they do an obstetric ultrasound at least in each trimester. But if not possible, at least at 24 4 weeks, they do an early ultrasound to estimate the gestational age and detect abnormalities and to impregnate.